make your shift, go get the refill, go get some food, throw your stuff away. 2 minutes.
Petrol. It's so good. How are you?
I have 5 a.m. class.
Do we? I'm just so
Yes.
And the guy on the list was all
And by that I mean like it's not without another excellent.
yesterday or today I was on call. I just kept repeating. It was like a kid that I got about.
It's sort of like
One other all normal.
Yeah. She says, I mean, technically, you're just Canadian.
Don't look back at it.
There is an indication, but I was like, chronic pain on narcotics.
maybe it's just on us.
One of the things they go backwards at my wife.
It seems like a video of you about it. Like show everyone. I'm not going on research.
East and I on
I know, I heard.
All right, I'm going to pull us back together now for the remainder of our meeting. I am honored to introduce our speaker today, who is giving the annual Frank Cerra lecture. Dr. Cerra is online with us today. Welcome, Dr. Cerra. Dr. Cerra came to the University of Minnesota in the early 1970s at the behest of Dr. Najarian to begin the surgical critical care program. And he did. He's one of the godfathers, really, of critical care in the United States. He has been president of the Society of Critical Care Medicine. He also became the interim department chair for the Department of Surgery, and then he did such a good job in 6 months, they made him dean. And he served as dean and vice president of academic health affairs for over a decade before retiring. And in honor, his friends endowed a chair in his name, which I hold and I'm grateful for. Our speaker today is Dr. Karen Brasel, who is one of our ancestors here at the University of Minnesota. Dr. Brasel is the vice president of the American Board of Surgery. She received her medical degree from the University of Iowa and then completed her surgical residency here at the University of Minnesota, as well as a master's in public health. She then went to University of North Carolina to complete her surgical critical care fellowship, which is where I met her because she was my guide when I was interviewing for fellowship there. And she actually sold the University of Minnesota, and I did my fellowship here. She's a nationally recognized leader in many, many areas of surgery, starting in trauma and then moving into the education sphere. She is responsible for the implementation of the entrustable professional activities and works with other initiatives in the specialty boards of the American Board of Surgery. She's been on leadership of many organizations, and most recently the American Association for the Surgery of Trauma, and has been on the executive committee of the American College of Surgeons Board of Governors and vice chair of CSAP, which is really a fun thing to write for if you get the chance in the future. She's also a founding member of the American College of Surgeons Master Educator, and has also received the Association for Surgical Education Master Educator Award in 2020. So we're delighted that Dr. Brasel is here with us today. She currently works at the University, which is not on an airplane, or the American Board of Surgery. She practices at Oregon Health Sciences University, where she focuses on trauma, critical care, and palliative care. So we welcome Dr. Brasel today.
Thank you so much. It is both a whole lot of fun and extraordinarily intimidating to be back in a room where I spent a good portion of my surgical training and had to present my own M&Ms in this very room. My disclosure is that I am an employee of the American Board of Surgery, and unlike when you in some disclosures, I am responsible as a member of the board for anything I say, and so you can hold both me and the board responsible for anything I say. I'm going to start with 3 things that I am grateful for. I started an active practice of gratitude when I was a program director and would share that anytime I got up and talked with my residents and encouraged them to share that back with me. And so today, the 3 things that I am grateful for are, number 1, that Dr. Cerra's friends and the university thought of establishing an endowed lectureship in his name. That is particularly meaningful to me because I had the opportunity to round with Dr. Cerra when I was a resident. And if you had told that Karen Brasel that one day she would come back and give the Cerra lectureship, there is absolutely no way on the planet that she would have believed that. I am also grateful, specifically grateful for the training that I received here from many of the people who may be online and potentially in the room, and alongside many of the people who are in the room, and particularly grateful to what I have called my residency litter mates. And third, I still have quite a bit of family here in the Twin Cities, and I'm grateful that I got the opportunity to spend a little bit of time with my sister and other family during my visit here. Now, what I would like you to get out of the next bit of time are, these are my 3 objectives. I will, no question, I am a competency-based education believer. So hopefully we'll reinforce some of the advantages of that educational paradigm. I will give you some data. I consider it a hallmark of my training that we were trained in the evidence. And so I will give you some of the evidence that we have accumulated with respect to EPAs and competency-based education. And then I am, above all, I think, although I learned last night a nickname that I had during residency that I didn't know until yesterday. But I believe that I am a practical person and hope to give you some practical tips about the whole competency-based paradigm. So starting with the why, I believe one of the greatest compliments that you can give someone in the medical field is to say that I trust that person to care for me or to care for my family member. And as a program director, when I was able to sincerely tell parents at graduation that I would choose their child to care for me, that was you could see in their eyes really the greatest compliment that could be paid. Now, the flip side is to ask program directors if they have graduated somebody over the last period of training that they would not trust to care for their family members. And it turns out that in internal medicine, anesthesia, orthopedics, and pediatrics, they have asked that question of program directors. And between 1/3 and 2/3 of program directors in these specialties have said, yes, I have done that. I have graduated somebody from my program, the program I am responsible for, that I would not trust to care for me or my family member. Now, I don't know whether it's that general surgery program directors aren't as brave to put those data out in the world, but I do know that when you get a group of general surgery program directors together behind closed doors, at least one of them will say, yeah, I've graduated somebody. It's not that they're not competent, it's that I wouldn't actually choose them. I think that's a problem. I think my signature on an application to become certified should mean that I would trust that person to care for me, because my signature means that I am certifying that they can care for the general public. And before you think this is going to be a rant on the surgical residency training of the current era, I am an incredible resident advocate. I think this problem is because we have a communication problem and a problem aligning expectations and accountability. And I think that is our problem as educators and trainers and certifiers. And one of the reasons I think the problem exists is because our current system is weighted to the left. It is a fixed time, and we assume that everybody after that fixed time is going to come out with the same outcome. And we all know, whether it's by observing ourselves, depending on how introspective we are, observing our friends, observing our kids, observing our nieces and nephews, that we learn things at different rates. And so, if it's a fixed time, there is going to be a variable outcome. And the assumption with training is always that the variability is going to be above the floor, so that everybody is going to be competent and the variability is going to be up from the variability. And we have no data with which we can back that assumption up. So the goal system would be to decrease the variability, not to get rid of the ceiling, but to raise the floor, to assure competence so that we are improving the health for everybody, to improve feedback, and to increase autonomy. The residents here may be different than residents across the country. I have my doubts. Residents across the country, two things that they would like: more feedback and more autonomy. Now, y'all may be different, and there may be other things that you want, but that's been pretty consistent when I talk to residents across the country, and certainly was true of my own residents. So that's the why and the where we're hopefully going. And the how is competency-based education. Competency-based education starts with knowing where you want to go or where you want to be. And where we want to be with competency-based education, and this is well beyond surgery, is to improve the general surgical health of the population. That is the outcome that we are aiming to get to. So that's the defined outcome. And the rest of the talk is going to be down in the assessment area, and that is the entrustable professional activities. It is important to know that EPAs, entrustable professional activities, are not the be-all and end-all of competency-based education. They presume tailored teaching when their results are taken into account, tailored learning, a sequence progression, which then results in where we started, our goal of improved general surgical health for the population. One of maybe the biggest difficulties in implementing competency-based education is that we are asking a group of incredibly competent surgeons, many in this room, many across the country, all across the country, who trained in a system that did not focus on competency-based education and who are competent, to look in the mirror and to then to turn around and say, we can, could, should do things better. in the midst of everything else that we're asked to do, increased RVUs, increased documentation, increased clinical concerns, we have to look and say, maybe we should change the system that's trained me and I'm okay and the train is actually running. That is a very difficult thing to do. And I'm going to give you two reasons for the why, that it is really important to say the system that's trained me and trained me well deserves a relook. The first is that the doubling time for medical knowledge has changed significantly. And you can put yourself on this arrow as in terms of when and where you trained. But the doubling time for medical knowledge is shortening monthly, and obviously shortening on an even shorter time frame than that. There is more to know. And when I think about many of the questions and many of the foci of what I was taught, I was asked to keep in my brain things that now can be looked up incredibly easily. And if I could not answer those, then the assumption was that I did not know what I was doing. So the focus of teaching now, there's no way that we can continue to ask the same questions of our trainees when they can get those answers much more quickly. We need to be teaching them differently and teaching them how to think, how to access, because things are changing so quickly. There's no way that they're going to be able to answer the same questions with the same assumptions that we make about knowledge. That's the first reason. The second reason is actually probably more important. And again, you can put yourself, we talked a little bit last night, and I think in my introduction, Dr. Chipman called me old.
I didn't.
An ancestor?
It might have been, okay.
I think you called me old.
But I was thinking of it in the Disney way that ancestors are respected.
Appreciate that. So you can put yourself in a category here, and these are data from outside medicine, but are consistent across all areas of work in terms of how you like to receive feedback. And the current way that is required by the ACGME are semi-annual reviews, and that tells you the last time that the ACGME Common Program requirements were reviewed. The people in charge, that is how they wanted to get feedback, how it was thought of as optimal. So the whole no news is good news, telling somebody twice a year or routine check-ins with summative feedback is not how current generations want to receive feedback. And as importantly, it's not how they've received feedback all the way through their education. So they've received feedback in real time, and then they get to our training paradigm and we give it to them in a completely different way, which goes back to, I think the problem is an alignment, not the fact that the residents don't know what they're doing. So some of the advantages of entrustable professional activities address those problems of alignment and problems of feedback. First, there is an alignment of expectations. So a shared mental model. What I expect of the residents, what faculty expect of the residents is written down. They can look at the entrustable professional activities. They know what they're going to get feedback on. They know whether it's in clinic, whether it's in the operating room, whether it's post-operative care. They know that whether it's caring for a patient with biliary disease, caring for a patient that needs renal replacement therapy. The EPAs help overcome barriers to feedback. All of those behaviors are written down. So even though as a faculty member, I haven't been taught how to teach, all I have to do is say whether those behaviors were exhibited or not exhibited. There's a script there. As a faculty member, it makes it very easy to give real-time feedback. It helps kickstart teaching, and we'll talk a little bit more about that. They also help promote a growth mindset rather than a summative, you did well, you get an A, you did well, you did poorly. What can I do better? What can you do better the next time? And then we'll move on. We're not going to keep that feedback in our brain in terms of you're a good, you're a bad resident. You're going to keep the feedback in your brain in terms of what you're going to change during the next encounter. And then for the members of the CCC, entrustable professional activities can help make CCC meetings and processes more efficient, decrease the time that it takes in CCC meetings by about 50 to 60%. So with respect to feedback, oftentimes as faculty, we think that we're giving good feedback. We spend time on end of rotation evaluations. So I don't know how many residents might have gotten an end of rotation evaluation that was a month late, 3 months late, 6 months late. If you're not looking over there, there are some nods on that side of the room. And might have some words along the lines of doing well, appropriate for level, needs to read more. All of those things might actually be true, but they're not helpful in terms of promoting resident growth. So feedback on a Likert scale is not a helpful way to promote growth. It's not the talking at is also not a particularly helpful way to promote growth. True feedback actually needs to be a conversation and needs to be thought of as feedback rather than summative judgment. I don't know how many have played sports. I maintain that the reason I was accepted into the Minnesota residency was that I was able to talk about sports, to specifically talk about Big Ten football at the time and hold my own in that conversation. But if you've ever played sports or again had a relative play sports, the practice and games are videoed. So that video can be reviewed. And the purpose of a video review is real-time feedback to say, hey, you need to change the way you are standing in the batter's box. You need to change the approach when you are passing the soccer ball. The purpose of the feedback is change so that the player will become a better player. That's the purpose of all of our feedback to surgical trainees who are learning a technical skill very similar to whatever sport. And feedback, I am not going to get into EduSpeak. I said I was a practical person, but in order for feedback to be effective, it needs to fit into some educational model of feedback. That's the whole reason that theoretical educators develop these models. And entrustable professional activities actually do fit into this model. They have to be requested, that you have to actually give them to the residents, or they have to receive them in a timely manner. They reflect on the feedback, they respond to the feedback, and resolve by changing behavior. That is in opposition or in contradistinction to the old feedback sandwich, which if any of the faculty have gotten professional development in the area of teaching, you may have heard of the feedback sandwich. It doesn't work. And the reason it doesn't work is those that you want, those who you are giving the feedback to that you want to pay attention to the middle of the sandwich, the thing that you are telling them they should improve, So you give them something they do well, something they should improve, something they do well. Those that you want to pay attention to the middle only pay attention to the two on the outside. And those that you want to pay attention to the two on the outside because they need to their competence to match their confidence, only pay attention to the thing in the middle. I would like to give you, because the feedback sandwich is so ingrained in our way of thinking, a different type of sandwich to remember. And this comes from one of our ATLS educators, who was actually one of my medical students and residents at the Medical College of Wisconsin. He has 3 kids, and at the time, his middle child was 8. And he was making this child, maybe all of his kids, lunch and making a grilled cheese sandwich. Makes the sandwich, gives it to his daughter, and she takes a bite and then says, "Dad, can I give you some feedback about this grilled cheese sandwich?" And then she proceeded to tell him how she would rather have her grilled cheese sandwich done. Now, she wasn't saying, "Dad, I hate you." She wasn't saying, "Dad, you're not a good father. I like Mom better." She wasn't saying, I'm not going to eat lunch. You have to fix me something else." She was simply saying, "The next time you make me a grilled cheese sandwich, I'd like you to do it a little bit differently because I like it a little bit different. I'm going to eat this one fine, and let's move on, and then we can go play." This is how we need to think about providing feedback. It's a piece of information and not a value judgment. I talked about the shared mental model. It is much easier to give feedback as a faculty when I know that the trainee that's working with me understands exactly how I'm going to evaluate them and what I'm going to evaluate them on. And as a trainee, it's easier for them to know that exact same thing rather than think, "Oh, does Dr. Brasel do it this way or does she do it another way? And I can't remember, and I'm all in my head about that," rather than thinking about what I need to demonstrate in order to get better. This is an example of some of the behaviors associated with the intraoperative phase of the EPA related to gallbladder disease. It's not particularly important that you notice all the words, but from a faculty standpoint, giving feedback, this is your script. I saw you try to show me the critical view. You were able to tell me what the critical view was, and then I had to help you in order to demonstrate it fully. You were able to get into the plane when you took the gallbladder off the liver bed, but you deviated some, and I had to help you stay in the plane. That's the feedback. There's the script. And as a result, I'm going to entrust you at the level of direct supervision. And in order to move to the next level, indirect supervision, again, the feedback is right there. EPAs also help kickstart teaching. I'm going to see if this conversation is relatable. How many of these cases have you done? 12. That's pretty decent number. I've done 12. Oh. So instead of this conversation, which is repeated over and over and over daily across all surgical programs, I would venture to say all 369 across the country, how about I saw that you've been at indirect supervision for your last 2 cases. Tell me what specific skill you'd like to work on to move to practice ready. That's so much easier for me as a faculty member, particularly because I am an acute care surgeon and have a little bit of the squirrel aspect. Now you've told me exactly where you want me to focus and when you want me to focus. And I'm going to give you feedback on that. And the rest of my feedback can actually be a little more general. Makes it much easier for me as a faculty member. Or how about this? Here's my last EPA microassessment. I'll even show it to you. Since then, I've done 3 more cases. I didn't get EPAs on those, but I've worked on that skill, and that's what I want you to give me feedback about. All right here on the screen. EPAs also help moving from a performance mindset. I really want to tell you all the things you do well. I really want to acknowledge that you work hard, that you're appreciated. But if I do that when you are not demonstrating specific skills, I might actually be harming my future patients and your future patients. And so you should actually want me to tell you what you are doing wrong. That helps you. That helps your future patients. It helps my future patients. And all of this happens under direct supervision. So when Dr. Acton tells me what your performance was on his rotation, that doesn't matter. You get a completely clean slate when you come work with me. If I don't see it, then I can't give you feedback about it. I don't care what somebody's told me. I don't care what might have happened in the past. I care what I see demonstrated. So now I'm going to share some data. It is well known in many fields and has been shown in surgery that subjective evaluations penalize women. That women who are evaluated, the end of rotation evaluations, are systematically evaluated at a level less competent than men. And we know that using entrustable professional activities, again, much less subjective, based on behaviors, has eliminated the majority of that subjectivity. It's still true that on self-assessments, EPA self-assessments, female residents rate themselves as less entrustable than male residents. We haven't solved that problem. And we don't know what happens for residents of color because we don't have enough data. These are the number of microassessments that we are using to make, to do some of the research and to make some of the decisions. For general surgery, the year 2023-24 was the year of progressive engagement. So by the end of academic year 23-24, the requirement for general surgery programs across the country was that at least one EPA for at least one resident be completed. It's change implementation, which goes slowly. So that was the requirement for that year. And there were over 100,000 microassessments. And these were just microassessments that were completed by faculty. There's another, it's about 50-50 in the national data set, 50% that are initiated and completed by residents, and 50% that are initiated and completed by faculty. And then the data in the table are from the ABS app that's hosted by Simple. There are 2 other platforms that you can see on the left, and when you add those in, it's over 300,000 microassessments in the second year. And now we get about 35,000 microassessments per month. So the total data set now is well over 500,000 microassessments. The most common gallbladder, the least common pancreatitis. And when you combine small bowel obstruction, consult, the pre and postoperative phases, as well as the resuscitation phase for trauma, that is the non-operative approach. About 35% of the microassessments are in the non-operative, assessing non-operative skills, if you will, and 65% are operative or procedural. Looking at the CGSO EPAs, they have made a concerted effort that 50% of their EPAs address non-operative skills, understanding that the discussions in clinic, the decisions about whether to give adjuvant, neoadjuvant, the palliative care decisions in the CGSO world, that is what they are interested in assessing their trainees. This table also highlights or foreshadows some interesting discussions that we will have over the next 3 to 4 years, whether assessment should drive curriculum or whether curriculum should drive assessment, or specifically related to pancreatitis and maybe related to the EPAs in the box above: renal replacement, thyroid, parathyroid, and small bowel obstruction. There were some very, very strong opinions that the care of patients with severe pancreatitis is in the realm of general surgeons, and it must be a part of the EPA suite. There is now an opinion looking at these data that across the country, healthcare has decided that maybe the care of patients with severe pancreatitis is not primarily in the realm of general surgeons, and that will be a decision about whether we should eliminate that EPA from the general surgery suite, or should we make a concerted effort to provide more opportunities for trainees to be evaluated in the care of patients with severe pancreatitis. These are the entrustability from the formative microassessments by PGY year. So you can see that the majority of formative microassessments for PGY1s are in the limited participation and direct supervision, and the majority for PGY5s are in the indirect supervision and practice ready. Now, I'm going to talk a little bit more about does this mean, or what does this mean about the entrustability of PGY5 residents. But remember, these are the formative microassessments. I will tell a story about a chief resident on the trauma service who we got the page that a trauma patient was coming in, all text page. So we were able to see, looking at the pager, that the patient was hypotensive. This had been a penetrating injury, and not only was the patient hypotensive, their Glasgow Coma Scale score was low, so not perfusing their brain particularly well. Gets to the trauma bay, the resident does the pre-brief, runs the resuscitation quite well. We take the patient to the operating room. The outcome for the patient is great. And then I have a discussion with the resident that for the resuscitation, his entrustment level was direct supervision, because the behavior that I had not seen was ensuring that blood was going to be available, and that the nurses understood what to do with the blood that they needed to hang during the resuscitation. This resident had completely done everything else well and would have been one of the 8%. That did not mean that at the end of the rotation, I thought that resident was entrustable at the level of direct supervision. It meant for that one case, that was an entrustability for direct supervision. This is what we know about entrustment over the chief resident year, that chief residents, if you start the chief residency year in July, that somewhere around 40% of those formative microassessments are practice ready. And that if you end the chief residency year in May, that rises to about 75%, showing the growth that happens during the chief year, and also showing the experience that many chiefs enter that last year of training with. And that entrustment progression is affected by case complexity. So it is easier or more common for chiefs to demonstrate entrustability in cases that are less complex. So what do these data say about the competence of chief residents and other residents? They actually don't say anything. They are formative micro assessments. That is information that has been provided to the residents. So the summative entrustability might take those formative micro assessments into account, but also needs to consider the time frame, whether that is earlier or later in the residency year, and also understanding that there is a lot of observation that happens that is not covered by EPAs. And so that entrustability, EPAs are only one piece of that entrustability, summative entrustability decision. What are the additional data about feedback? We know that residents on a national level who get more EPAs are more satisfied with feedback. And that is true whether that comes from a good rotation, rated as good by the residents, faculty who are good teachers, or bad rotations, faculty who are not appreciated as much by the residents. And that is all correlated with EPAs. So these are data from other specialties, which launched August 1st of 2025. There have been over 1,500 microassessments from CGSO, up to over 6,000 microassessments from vascular. And these are the 4 other specialties within the American Board of Surgery that have launched their competency-based initiatives. Transplant is talking about it and has started work. There are also entrustable professional activities for the specialties that are housed within the Fellowship Council. So endocrine surgery, minimally invasive surgery, to name a few. So what does the future hold with specifically related to EPAs and competency-based education? Better feedback to those who are submitting data, not only program directors and program administrators, but individual faculty and residents, and that is coming within the next month. That those data will contribute to an engagement report, but also an entrustment report and individual user reports. What will be required from the American Board of Surgery? So up until 2028, you need the things on the left to apply for your qualifying, to sit for your qualifying exam, and you need the signature of your program director. Starting in 2028, you will also be required to submit an EPA profile. You, the resident, will be required to submit an EPA profile. None of the EPA data comes directly to the board. We know nothing about the entrustability of an individual resident at the board level. All of the data that I showed you are, all the research and the data that I showed you come from de-identified data. So you get your microassessments, whether it's direct supervision, practice ready, that is information for you, for your faculty, for your program director, for your program. The board doesn't know it. The other thing that will be coming is is work that will help CCCs take the micro assessments and come to a summative entrustment decision. And there's some work that we have done already to help with that, to help with those summative decisions. But again, that is that reporting to the board is in the hands of the residents and in the hands of the CCCs. So we talked at the beginning about the fixed time leading to a variable outcome. The question that springs to many people's minds is, if we are moving towards a fixed outcome, does that mean variable time? The Blue Ribbon Committee, made up of surgeons from the American College of Surgeons, the American Surgical Association, the board, and many others, has put out a paper suggesting that general surgical training can be accomplished in 4 years. To me, that may be true, actually. If we're able to truly move towards competency-based education, I actually don't think that will happen in my working lifetime. And I think it's the wrong thing to be thinking about now. I think the most important thing to keep front and center, the true north, is that what we want is a fixed outcome, to eliminate the variability, to improve the general surgical health of the population, and to do that with assurance, and to do that as a community that is made up of both residents and faculty engaged in dialogue about competence and performance. I think that with that goal in mind, we have done a lot of work, and there's still a lot more work to do. The launch of EPAs and the path of moving to a competency-based training model has given us a lot more information and put a lot more and better information in the hands of the people who need to use it. We know that feedback has improved on a national level. No idea what's happened here. And I do believe that competency-based education helps all of us, whether we are program leadership, whether we're individual faculty, or whether we're residents. This has been an incredible, incredible honor, and I'm looking forward to talking to more of you throughout the rest of the day. And I would be happy to take any questions, and please make them hard. Those are the ones that are the best and the ones that help drive this process forward. Thank you.
What questions are there?
Wonderful talk, Karen. It's great to see you again. And I do want to publicly thank you for teaching me the Aberdeen knot when we were in conference together at Regents. Night eating our bologna sandwiches or whatever, they had dog food stuff. And I go, what the hell are you doing? You taught me how to do that, and I still use it now. But I digress. It's nice to see you've gone beyond the degraded sort of shading blue slides with the yellow and white type that we read in us 40 years, 30 years ago or so. But the obvious question is, in 2 years, when our residents have to submit their EPA profile, is there going to be a benchmark that they have to be at in order to sit for the written board? So say we're in this step, or when will the board make that move? Say we, Dr. Kendrick submits a resident A who has only gotten direct supervision for everything at their chief year, and he's not proposed a plan for remediation and lets them go through. Will the board then step in?
So I do believe that you just called me old too, Bob.
I understand. Jeff and I are good friends, so we tend to talk a lot alike.
I want to be super clear about this. What's required in 2028 is to submit a profile. It doesn't matter what that profile says. That's the start. This is change implementation on a grand scale. And the first thing is to make sure that people can do this. If this doesn't work, then it doesn't do any good for people to require it. The reason we have an app that is provided by the board to everybody for free is because of the pilot that we did from 2018 to 2020 that showed that sites that had developed their own electronic app to record microassessments were the successful sites. And so when the pilot leaders then went to the board to say, we think this idea has legs and can work and is really important, and programs don't have the money to pay for it. Faculty don't have the money to pay for it. Trainees don't have the money to pay for it. This is only going to work if we, the board, will provide this app for free. Because any other system, and the Canadians went a different way, and their experiment in competency-based education is having significant issues. And they're learning from us, we're learning from them. So in 2028, all that's required is the profile. Now, do I think in 2038 that's what's going to be required? No. I don't think that the volunteers of the General Surgery Board on the American Board of Surgery are going to accept having board certified surgeons that are only competent for direct supervision.
Should we ask those volunteers? They're right there.
Some of them are over there.
So, but it is going to be an incremental process to figure out how we get to that point that we have that assurance. But 2028 absolutely will not be.
One of the things I appreciated a lot is that the emphasis that this is formative feedback, not summative. And, one of your consultants is formerly from here. And our medical school, I think, is at the forefront of competency-based evaluation, but it's really more on the summative side of things. And what do you think about that? Do you think we're there? Do you think we're ready to make this summative, at least in the medical school side of things?
So I will say that I would leave all the medical school stuff to you and to Bob. I do not have any expertise in undergraduate medical education. Some of the things I think translate as an individual teacher, but from a leadership perspective, do I think we're there right now? No, I don't think we're there right now, because I think that although some of us as teachers might say this is formative feedback, we behave as though it is summative. And I think as a group, we often behave as a group, i.e. the departments, we behave as though it is summative. And I don't think the residents trust us. And I think they don't trust us for good reason. And so I think it will take time to get to where they believe us, they ask for formative feedback, and they trust that when the time for summative decisions happens, it will be reflective of their overall performance. I do believe we will get there, and I do not think we are there now.
Thank you for your talk. I think it's helpful as people, as trainees who are coming into this, what we should be taking away from the EPAs, because sometimes it's difficult to tell what is wanted from this system as it's getting introduced. I guess part of my question is, if you feel like the feedback that residents are getting is meaningful feedback, because sometimes right now, you're having direct conversations with staff, and it probably prompts some of those conversations. But at the same time, when does this become just button clicking, which is just something that starts happening? And we talk about button fatigue with Epic and just having to click everything. And so how does it not become that, where it's just, okay, I finished a case. I know that as a PGY2, the expected level for me is, direct supervision on this. And that's kind of what I felt. Boom, boom, boom. Here are my buttons. Send it to the staff. They do the same thing. And that's the extent of the feedback that I get, because it's limiting how do we stop from doing that and keep it meaningful feedback that we're getting?
Yeah, I think that the majority opinion that I've been able to both hear and solicit is that while the entrustment level is helpful feedback, the most helpful feedback is the narrative or the text feedback. And that is something actually that is in the hands of the programs to incentivize. I've and again, we don't even at the board level, because feedback is super hard to the narrative feedback is super hard to identify. We don't even know how many of the micro assessments have narrative feedback, whether that was actually narrated or typed in. We know from some other work that it's about 75% of the micro assessments have narrative feedback. And I have heard from the faculty side, well, I told the resident that we don't need to actually record it, but that means that the resident doesn't have the opportunity to go back and review the narrative feedback in the whole coaching video manner. I don't have a great answer for the button fatigue, other than it is the way I look at it, it's a balance between the number of EPAs that will ultimately be required and the value that are put in. So rather than saying you need to get an EPA for essentially every interaction, which some people have espoused, maybe 2 EPAs per week. And as you see the value, this is ultimately got to become a value proposition and have value both for faculty and for trainees, because extrinsic motivation only works for about 6 months and then it stops. But things that people value, they will continue to do time after time after time after time.
Dr. Brasel, thank you very much for the wonderful talk. And for all of you, I work for Dr. Brasel at the Believe me, I serve in many associations, but this is the most strict one. The meetings start on time, meetings end on time, no texting during the meeting. That's the only place I have. They run it like a military. Thank you. So my question for you is as follows. There are many students here, young residents, some of them want to be academic transplant surgeons, right? The current pathway for them, they have to do 5 years of general surgery, 2 years of research in between, and then they have to do a fellowship, 2 years. If they do something like pediatrics, like me, they have to do it for 4 years. We're talking about 5 plus 2, 7 plus 3. Now, as you finish all the EP, etc., is there any opportunity for our residents who are the cream of the cream to see that those that are going into research can have competency-based advancement, not necessarily log in the 5 years that they have? Because one of the reasons I worry about it is that a lot of these, they're looking at other specialties, for example, pediatrics or internal medicine, etc. And we are losing some of the brilliant students to those fields. So what are your thoughts about academic residents that come to research?
Yeah, I think that sentiment lies behind the Blue Ribbon Committee's thought, and that 4 years really was, although not exclusive to, really focused on people who were trainees that were interested in pursuing fellowship, and that there might be portions of general surgery that might not be necessary if you chose to train in a different specialty. Again, I think that because the approach that we have taken is we need the data in the community to inform and drive our decisions. This cannot be a totally top down. We can only move at the speed and the trust that the community will allow us, and we can only make decisions based on the data and when we have enough data to make those decisions. when you look at the data from the chief resident formative microassessment, you can see that there are going to be some chief residents in there that when the fellowship EPAs are available to them, they can start asking for microassessments on the fellowship EPAs. And so even in a fixed time model, they can start to demonstrate competence and get feedback about a different specialty, because at least within the American Board of Surgery. So they could then show Dr. Acton, I am already at the level of indirect supervision for 3 of the pediatric surgery EPAs. And then maybe that's where we start shrinking the time of overall training. Again, do I think that there will be some variability? Yes. We have already taken the step of using EPAs for training time waiver requests. So if one of the chief residents, and I don't know where in here the chiefs sit, but has something that happens in the last year of training such that they break their leg and they are not going to be able to make the required time, and they're going to be off by a week or 2. Dr. Kendrick can submit a request to the American Board of Surgery that includes EPA data, the number of faculty, and the most recent summative decision by the CCC, that the committee at the board that takes a look at this can say, this resident is already practice ready. And we all know that requiring a chief resident to do 2 extra weeks or 2 extra days in July benefits nobody and does not change competence 1 iota. So we are already starting to look at our policies and see where we can help use this information. It's a very long answer. Sorry, I'm long-winded.
Thank you. This was a wonderful talk. I believe that in a program like ours, that we work in different sites, that has a lot of advantages. But one of the downsides is that we sometimes, don't work in a site for 6 months, and then when we go back, you basically start from zero. What specific feedback do you have for us, or recommendations you have for us as residents and for faculty members to be able to provide more continuous feedback, since we don't have that in comparison with programs who have a single site and they work continuously or longitudinally with the same faculty all over again?
Yeah, one of the things that I think that at their best, when implemented to their best and fullest, EPAs can do is really place learning in the hands of the trainees, so that you can then go to this site and the faculty at that site that you have not worked with or at for 6, 8, 10 months. I think I spent 2 or 3 years between my rotations at the university here, and was at the VA and at St. Paul Ramsey during that time, and then came back. But then you can say, these are my last microassessments, and Dr. Acton, working at a different site, should actually trust me as the faculty who's provided some of those assessments, and you can show that to them so that they have a base from which to judge you. They might still want to see a little, but it at least gives you some leg up. And the more information you can show them, the better, rather than them saying, I don't even remember you, or something similar.
Last question to Dr. Ack.
Just a couple comments. I mean, I think it was like 2017 at APDS. I think it was MCW. One of the programs that really bit hard in the simple was the first one that tracked all their residents through their 5 years and showed specific simple curves for their residents going through 5 years of training. And the curves are just phenomenal. Each of them had about 1,000 simple assessments. They worked hard at it. I might have the wrong program. And it was just amazing how those curves tracked out, and all the noise of all the various assessments just fell away from people saying this, Kendrick's mean, he grades me really hard. Shipman's a dove. Those sort of things. That stuff just went away. To my question though, so that's where I bit in hard. I remember talking to you some about it at that time as well, Karen. That my other hats is on the credential committee, and part of the hospital aspects there's been whispers of starting to ask people coming in to give us their EPA profiles as we consider credentialing them at places. Just sort of whispers on the hospital sides and some of the meetings I've been at. Have you heard any of that at the board per chance?
I
It
have.
is a person's data, correct? And so the hospital could ask them for it.
The hospital can ask you anything,
Correct.
just like your fellowship can ask you anything. Fellowships have been asking for ABSITE scores for years, and that's a complete misuse of ABSITE data, which is a formative exam and not supposed to be used for any type of summation, despite the fact that 2 of my residency littermates were fired for ABSITE scores way back when. So you cannot prevent people from misusing data and information. That's an impossibility. The data aren't owned, the individual identified data are owned by the resident and the program. They're not owned by the board. The board owns the de-identified data set. So the board can make a statement, as it has done with ABSITE, that these should not be used, that they are formative microassessments. State licensing boards, at least in some states, ask for performance evaluation that is in resident evaluation files already. This is no different. So do I have not heard of that. The board would not be in support of that, but does that mean that it won't happen? No, it doesn't mean that it won't happen. I have heard of residents using their own data to send to a faculty member who is writing them a letter of recommendation so that they can include some of the language about competence in letters of recommendation. But again, that is in the hands of the resident and the trainee. And I guess the last, do we think these are discoverable? And we don't think these are discoverable.
Thank you all very much, Dr. Brasel.
Thank you again.